Welcome to PGOG postgraduate class in obstetrics and gynecology, and today we are at the last class on abnormal uterine bleeding, that is part 3 is management of abnormal uterine bleeding. The first step in the management is always to rule out pregnancy, as abnormal uterine bleeding is a disease of reproductive age group. Second is to rule out cervical lesions if there is intermenstrual bleeding or there is a history of postcoital bleeding. Various cervical pathologies which we can get are cervical erosion, ectropion, polyp, or cancer. Now, so many times what I have observed is postgraduate students have a confusion how to differentiate between erosion and ectropion. Now, remember that erosion is where the squamous epithelium is being replaced by columnar epithelium, and it also looks red. Ectropion also, there is a redness around the external os, but what you will observe is whenever you examine a patient, there is a eversion of the anterior and posterior lip that leads to the exposure of the columnar epithelium. Excessive exposure is there. There is no replacement of squamous by columnar, but it is the exposure of the endocervical canal. It is because of the usually trauma during vaginal delivery, which is leading to very minute lateral cervical tears at 3 o'clock position or 3 o'clock or 9 o'clock position, and that leads to the eversion of the two lips of the cervix, anterior and posteriorly. And this eversion, if you can understand, I hope you understand it. It is like opening up. I'm sorry whether I am able to show you is, now suppose this is the normal cervix. What will happen because of the lateral tears is anterior and posterior lips will open up, and this opening up leads to the exposure of the endocervical canal, which looks like red. So how we know is the lips are seen, anterior and posterior lips, there is a transverse slit, history of previous vaginal delivery, and you can then see that there is a eversion of the lips, that is called as ectropion. Polyp can be seen, which can be endocervical polyp or endometrial polyp, and if it is this, sometimes we can see that it has a small polyp which is arising from endocervical canal, then it will be cervical polyp. And cancerous, if it is a growth over the cervix, that can also be seen. Now, remember that in the palm coil, we have M, but it does not include cervical cancer. It includes endometrial cancer, endometrial hyperplasia, and leiomyosarcoma. So, if there is a cervical cancer, the management is completely different and it doesn't come under AUB as far as FIGO classification goes. What investigations we do is CBC is mandatory, as with the heavy menstrual bleeding there can already be existence of anemia, and we need to rule out thrombocytopenia as a cause for heavy menstrual bleeding. Pregnancy test, as I said, it is a disease of reproductive age group, and one should never forget that always whenever there is a heavy amenorrhea, short amenorrhea, heavy menstrual bleeding, or even if in absence of amenorrhea also, we need to rule out pregnancy. TSH needs to be done, as both hypo and hyperthyroidism are associated with abnormal uterine bleeding. Complete coagulation profile will be indicated, as we have seen in the last class, if the coagulation screen is positive. In short, if there is a heavy menstrual bleeding since menarche, any one of PPH, surgical bleed or dental bleed, any two of bruising, epistaxis, gum bleeding, and positive family history. This, all the postgraduates need to be knowing about this screen by heart, so that we are sitting in OPD. When we take the history, that itself gives us the indication whether to write advice complete coagulation profiles such as PT, APTT, and for the von Willebrand test to rule out von Willebrand disease. All these are expensive investigations, and that is why this screen helps us, clinical screen. This is called as a coagulation screen, which is clinical. On history only we can decide whether to proceed with the complete coagulation profile or not. Ultrasonography, abdominal as well as transvaginal sonography, which will help us mainly to diagnose polyp, adenomyosis, leiomyoma. And if thickened endometrium is there, it will be suggestive of either endometrial hyperplasia or endometrial malignancy, especially if thickness in the reproductive age group, endometrial thickness of more than 12 millimeters is considered as abnormal. Though endometrial thickness helps less in uh, diagnosing or helping us to know whether the patient has endometrial hyperplasia or malignancy in reproductive age group, it is of less value as compared to its value in postmenopausal age group. Now, for students, I want to make it clear, as I said, cervical pathologies, especially cervical polyp is there, but otherwise cervical cancers are not included under abnormal uterine bleeding. Same way, what you should understand is whenever we are talking about this polyp, adenomyosis, leiomyoma, and malignancy, then we should also understand that this PAMPAN classification system does not include postmenopausal bleeding. So this I want to stress again. Cervical cancer is not included. Postmenopausal bleeding cases are not included under this AUB. It is specially the terminology, and this classification system has been designed only for the reproductive age group, that is from menarche till menopause. MRI is indicated whenever we want to know the specific details, such as multiple leiomyomas are there, then we want to know where is the placement of leiomyoma, if we are planning to do the myomectomy, or if there is a suspicion of endometrial malignancy, then to know how much is the invasion. Like all these indications, especially for adenomyosis, sometimes ultrasonography gives us the sufficient indication, but for confirmation we can go for MRI. So MRI is not indicated in all cases. It is indicated in for the specific details for the specific patients. Now, since many years, this is a point of debate when to do the endometrial sampling in abnormal uterine bleeding. When I was doing post-graduation, we were taught that any patient above the age of 40 years, then first you do endometrial sampling and then only you start treating a patient. That means you rule out endometrial carcinoma, which holds true today also, except that now the age limit has been increased to 45 years. Especially if there is an ambulatory AUB and age is more than 45 years, then all the guidelines, say COG, RCOG, or even the Foxy guideline, that is also recommending to do the proceed with the endometrial sampling in these patients when there is a irregular, infrequent bleeding, heavy menstrual bleeding, prolonged bleeding, which is suggestive of anemoulation, and patient's age is more than 45 years. Less than 45 years, whenever there is a patient has a high risk factor for carcinoma endometrium, then one should proceed with endometrial sampling, such as obesity, PCOS patient, prolonged anemoulation is there, history suggestive of that, duration of anemoulation is prolonged, or whenever the endometrial thickness is more than 12 millimeters, then also one should do the endometrial sampling to rule out the endometrial hyperplasia or malignancy. Any AUB patient not responding to medical treatment is an indication to do the endometrial sampling. Now, how we get the endometrium for the sampling is either we can go for a office endometrial biopsy by using EB curate. Now, dilatation and curettage under anesthesia was done very frequently in the past, but it is no more being advocated. The reason is with that it has been shown by the studies that less than 50% of the endometrium is sampled. Even if we give anesthesia, shift the patient to OT, subject her to anesthesia complications, still dilatation and curettage is not very helpful. So that 50% of the endometrium which is not sampled might be containing hyperplasia or malignancy. Office hysteroscopy can be done and directed biopsy can be done, or hysteroscopy can be done in operation theater under anesthesia, and There, the evaluation of endometrium, presence of endometrial polyp, submucous fibroid, or the area where it is thickened endometrium is seen. So, directed biopsy can be taken, yeah, and that is why it is a gold standard histoscopic directed biopsy. But if it is not available, endometrial aspiration by using endometrial suction catheter is also advocated in all the guidelines. And one such is by using PPL, where there is a suctioning which helps for the endometrial tissue aspiration. It is not cytological examination. Whatever tissue we get, it is sent for histopathological examination. Now, this is one important concept I want students to understand is how we give the notation of AUB as per palm coin. Now, what is the whole idea of palm coin is it is based on this concept that more than one factor might be contributing to AUB. Now, what happens is so many times we do sonography and we find there is a leiomyoma and we stop evaluating the patient further is wrong. We need to evaluate for all the factors, palm coin. That means we need to thoroughly see whether there is any associated other factor. There might be coagulopathy in the same patient. She might be a case of von Willebrand and she might be having leiomyoma also. One example is how we write the notation is this patient has adenomyosis. Then you give a semicolon as it comes under palm coil. Same way. Then leiomyoma O is other than submucous and the patient also has ovulatory dysfunction. That means there are three factors. Now, whenever the leiomyoma is present and suppose it is a small 1 or 2 by 2 centimeters and it is not submucous, not necessary that it will be contributing to AUB always. It is present, it is detectable, it is structural abnormality which is easily detectable, but it is not necessary that always it will be the factor for AUB or it will be the factor contributing to AUB. Adenomyosis is also frequently diagnosed with more and more cases are being diagnosed with better ultrasonography machines or with the MRI. But still, in how many cases it contributes to AUB is still not very clear. And what is most important in this patient is she has ovulatory dysfunction. So always first line of management should be to correct her ovulatory dysfunction by giving the hormonal treatment, medical treatment. That might be the first. And if hormonal treatment is contraindicated, we can even try non-hormonal drugs also. LNG-IUS might be the correct option in this patient because the study's emerging evidence shows that LNG-IUS helps in adenomyosis, leiomyoma, as well as in ovulatory dysfunction. Now, this is one area which is very important is acute AUB. Patient has come with heavy menstrual bleeding and she's bleeding profusely. And you see that she has tachycardia and she has features of sometimes hemodynamic instability or hypovolemia also. Falling blood pressure might also be there. So how do we deal with these cases? Is we rule out pregnancy as we have seen in first slide only. Any management starts with ruling out the pregnancy. We quickly one has to assess clinically and first aim is to rapid clinical assessment for acuity. That means how much is the instability, how much is the tachycardia, how much is the hypovolemia, that we need to see a quick history taking and examination. And we start IV fluids and we start if she has severe anemia we need to give PRC, packed red cell transfusion and FFP transfusion. Then simultaneously we start looking for what might be the underlying cause for AUB. Whether she is bleeding profusely, whether it is a very large uterus with multiple leiomyomas leading to that, or whether she has got a submucous leiomyoma and she is bleeding profusely, or whether it is a plain and simple anovulation leading to profuse bleeding. So quickly we need to reach to that what is a probable cause, underlying cause. And then accordingly we need to decide for most appropriate management. So these are the first three steps on admission. Clinical assessment to know how much is the patient's condition is deteriorating, how fast. Second is to know the underlying cause and third is to decide appropriate best possible management for that patient. Objectives of the treatment are we need to control her heavy menstrual bleeding at the earliest. We need to prevent its occurrence in subsequent cycles. Medical treatment for acute AUB, one can try medroxyprogesterone acetate progesterone, 20 milligram 3 times a day, and can be given for 7 days. So it is a higher dose progesterone therapy. Or we can give combined oral contraceptive pills, low dose pills, where the dose of the ethinyl estradiol is are up to 30 to 35 micrograms. It can be given for 3 times a day for 7 days. Tranexamic acid can be given along with any of these two, 1 gram orally 3 times a day, or we can give 10 milligram per kg intravenously. Remember, 600 milligram is the maximum dose for any maximum per dose. That means if you are giving 3 times a day, you can't exceed it to 600 milligram 3 times a day. Conjugated equinestrogen is the drug which has been mainly been approved by United States Drug and Food and Drug Administration, and 25 milligram intravenously. It can be given every 4 to 6 hours for 24 hours. Now this is less commonly used by us. What we are mainly using is this, either high dose progesterone, or we can start with the combined oral contraceptive pills if there is no contraindication to it in a given patient. Now, when you try this and there is no response, one can try GnRH agonists in refractory cases. Once acute episode is controlled, then one needs to consider whether to put patient on LNG-IUS to prevent further heavy menstrual bleeding episodes, or to put patient on cyclically combined oral contraceptive pills or cyclical progesterogens. Surgical treatment such as D&C we used to do a lot in past, but it is no more indicated in these cases of acute AUB because we have better drugs. Tranexamic acid is there, and we have better hormonal treatment, and less patients are subjected to dilatation and curettage, because whatever, when she comes with a bleeding, profuse bleeding since last 3-4 days, already whatever endometrium was, it is usually the shading takes place, and then we miss sometimes a diagnosis of endometrial hyperplasia or malignancy because of that, and that is why it is not the correct time to do the endometrial sampling. Emergency endometrial sampling in acute AUB is of less likely to be of any use because of this reason, that already endometrium, whatever endometrium was there, already it gets shed off, and that is why we might be not be getting a report, though patient has endometrial hyperplasia, it might be missed. Endometrial ablation in emergency is rarely done, as usually the response to medical line is good. Similarly, uterine artery embolization in emergency, if there is a huge fibroid and she's bleeding, is less likely performed in emergency, and hysterectomy in emergency is almost not indicated with a better drugs which are available, and especially LNG IUS which is available. For chronic AUB, we have non-hormonal wonderful drugs such as mefenamic acid, tranexamic acid. In around 30 to 40% of the patients, it will take care of heavy menstrual bleeding. Correction of anemia is very important because quality of life, why AUB affects quality of life, one of the reason is this increasing severity of anemia. Hormonal treatment is combined oral contraceptive pills, low dose with newer progesterogens in elderly patients such as drospirenone, dienogest, or desogestrel. Cyclic progesterogens can be given such as medroxyprogesterone acetate. It can be started on day 5 and given up to day 25-26, or for last 10 days of the cycle it can be given, either of these two. Ormeloxifene is the selective estrogen receptor modulator which is tried, and it also sometimes helps for the correction of anemia and control of heavy menstrual bleeding for 6 months to 1 year. LNG-IUS has a special place in patients of AUB. It is very effective. It reduces heavy menstrual bleeding whenever there is ovulatory dysfunction or anovulation is the cause. It reduces the size of leiomyoma as well as heavy menstrual bleeding in AUBL, especially when the leiomyoma is not a submucous one. O is other, that is other than submucous. In adenomyosis, there is a strong emerging evidence that this LNG-IUS reduces pain, that is dysmenorrhea associated with adenomyosis, and also there is a reduction in the size of uterus also. So what is happening is inside the uterine cavity, this LNG is getting, levonorgestrel is getting released per day. It reduces the estrogenic effect of estrogen on these endometrial foci which are present in the myometrium, and that is how it reduces, so thought to be reducing the size of uterus in patients with adenomyosis. In AUBM, when there is endometrial hyperplasia without RTPR, then one can go for LNG-IVS rather than whenever there is a RTPR, then we are more worried about its getting progressed for endometrial carcinoma. And sometimes in these cases, we can go for hysterectomy also. But whenever it is endometrial hyperplasia without OTPR, then this LNG-IVS will be effective in reverting it back to a normal endometrium. It has its contraceptive action for 5 years. It is superior to oral hormonal treatment because the side effects associated with the oral progestogens or estrogen progestogens will not be there. For first 5 years, it is getting released at the rate of 20 microgram per day, and then it gets released at the end of 11 microgram per day. It contains total 52 milligram of LNG, levonorgestrel. It can be used now for contraceptive action. Its action remains for 5 years, but for AUB, it can be used up to 7 years. There are studies showing its efficacy up to 7 years in patients of abnormal uterine bleeding. It is so effective that it is known as medical hysterectomy. Surgical options, we have conservative surgery such as endometrial ablation or resection. Uterine artery embolization can be tried for leiomyoma. Myomectomy can be tried if patient is not desirous for removal of the uterus laparoscopically or hysteroscopically. Especially hysteroscopically, submucous leiomyoma removal is far conservative than taking a decision to proceed with hysterectomy. Hysteroscopic polypectomy gives satisfying results to the patient as well as the person, the clinician who is operating, because we are avoiding a drastic operative procedure as hysterectomy can be avoided. Though in many patients, definitive when patient fails to respond to medical treatment or as per the patient's consent, she is not willing for the conservative management, then definitive treatment will be hysterectomy in patients with abnormal uterine bleeding. Thank you so much. With this, we come to the end of this series on abnormal uterine bleeding. Thanks a lot.